patient Dr. Vijay from Madras Medical College came here to present about the case presentation on nose defect. My patient, 6-year-old female child, resident of Hyderabad, came to the hospital with a chief complaint of informant his mother and came to the hospital with chief complaint of soft tissue defect over the nose. It's past 4 months ago. So coming to the present illness, she had a history of dog bite 4 months ago, and she went to a nearby hospital, and then she got immunized and then anti-rabies vaccine, and then she was treated with only dressings, and then the wound was healed by secondary intention. And there is no history of swelling around the nose or discharge or any nasal bleeding present, and there is no any history of nasal obstruction, and there is no any history of any other trauma elsewhere. The past history is insignificant, and the personal history that she consumes mixed diet and the sleep is adequate, bowel and bladder habits are normal. The immunity history is as per the age adequate, and the development history also is again as per the age. Coming to the general examination, she is active and playful. The vitals are stable. There are no signs of any pallor, icterus, sinuses, clubbing, within edema. And coming to the systemic examination, the general examination all is normal. So on examination, patient in well-lit room, in the presence of mother in sitting position. My inspection findings are the face in frontal view. There is all the other is symmetrical other than the nose defect, in which there is an irregular full thickness defect can be noted that is present around the extending from craniocaudally from the dorsum, nasal to the columnar base, and then lateral border of the right ala to the lateral border of the left ala with exposed caudal septal cartilage. To coming to the subunit principle to tell about the percentage, there is 100% of tip loss, and there is 100% of columella, and there is 70% of loss in the left ala, and the 40% of the right ala, and involving also the 25% dorsum nasal.
You said that is the loss which you have measured? You said 70% of left ala.
Yes, sir. It's by seeing the picture itself, sir. So I got in the pictures.
How do you percentage by how you measure the loss in ala?
Sir, actually I have measured in this patient there is a bilateral ala defect. So I couldn't, contralateral defect I couldn't measure. So I took an ideal candidate who is of same age, that is same 6 years, and female child. I'll show the next slide. It's incoming.
Okay.
So on palpation, there are all my inspective findings are confirmed, and there are no signs of inflammation and no regional lymphadenopathy. And my diagnosis is post-traumatic sequelae dog bite. It's a composite full thickness defect of nose. And qualitatively, as I mentioned, the right ala 40%, left ala 70%, and tip 100%, columella is 100%, and dorsum nasal is 25%. And quantitatively, I have taken a 3D foil template measurement plan. This is a child of 6 years of age, another child, female child. So I took the same defect over the, I superimposed the defect over the same child, and then measured. So the right ala is around 0.5 centimeter, the columella base is 0.8 centimeter. The columella length of the column is 0.8 centimeters.
8 millimeter.
Yes, 8 millimeter. And the left ala is defect is 0.9 centimeter. The total ala is 1.2 centimeter. So it's around 70% for the left ala. And the right ala is around 40%. And the tip is inward. So the defect after measuring it's around 3 centimeters up till the scar, which was this is the scar, sir. So 3 centimeters craniocaudally up to the columnar base, and 2 centimeters wide from the lateral border of the right ala to the lateral border of the left ala.
So just to come to the, how do you do the true defect?
Yes, sir. This is an apparent defect, sir.
Yeah.
Yeah. Actually, it can be seen only on the OT table after debridement.
Okay, but with what is there on the child,
Yes, sir.
This child now has a defect. You've taken a normal subject.
Yes, sir.
How do you transfer those points onto the normal subject? Then you mark the You got what I'm saying?
Yes, sir. Yes, sir. In this patient, actually, we have only photos, sir. I have to
No, I'm just asking
Yeah.
you, how will you convert that into a
convert into
true
yeah.
defect?
The landmarks for the
So
the
from
first
this
we-
picture,
I
what
did-
landmarks will you take and transfer to the other picture and then take your measurements?
Yes. First, we'll mark for the.
So here what's
col-
happening is the scar is also pulling
Pulling
everything
the-
up, so you will not know where it is.
Yes, sir.
So from whatever you have, can you make an approximate guess of what your true defect is?
The true defect, definitely it will be more than the apparent defect, sir.
No, how will you measure?
Measure.
What from
So
where?
the landmarks for this, from the columella, I will take the columella base up to the tip and then to the dorsum, sir. For the craniocaudal length.
Columella is also a wide region.
Yes, sir.
You have to take a point.
So
And then you have to see how much
See,
is.
you have to transfer the
exactly.
same thing on a normal person. Now there must be some points to which you will measure.
Columella is not a point.
Huh?
Yes, sir.
So what will be the points on this patient, on alar side, on columella side?
So alar size will be alar base, sir, this side, and
Base is this much.
nostril, the apex of the
You
nostril.
have, just point
Yeah,
it out.
just
draw it,
point
draw
it
it
out.
here. Draw the points here so that. No, go back on the previous.
No.
lesson, yeah.
Take
On
pen.
that
Yeah.
photograph?
Can you
Yes.
mark on
Can you
your-
mark
Can you just pinpoint with a pen?
Your computer, can you mark it? Do you have
Just-
Or
a-
on computer?
do you have a writing pen on that tablet?
No, here,
No.
here.
So the
He
point-
has a, yeah, it doesn't matter.
Okay, okay, fine,
So
fine.
just show it.
Please mark. Point marker.
So first point I'll mark this side, sir. This is a normal side.
Okay.
Then I will take a thread, take a thread and then go up till the tip, sir. To measure
There is
the
no
alar.
tip. There is no tip.
This in this not ideal candidate.
No.
First you have to see the
The-
points on
The apparent defect
this
of this
patient.
patient.
No, so what we are saying is that you have to have some landmarks over here, and then you measure saying that so much of the alar is there, and you transfer that onto a
In effect,
normal patient.
which points will you mark here, which you will then point, you will mark exactly the same points on your normal
Normal.
person, right?
Yes, sir.
So which are those points? Right now, points.
You have already measured.
Then when
So
you
you
add
are-
up all the points, you will get your true
You will get
defect. So
the-
which points are they? That's all we are asking.
So in this patient, there is another person columella tip, ma'am. Tip.
Mark it, no, at the base of the columella, wherever you have, yeah.
So this is the base AMS, sir. AMS is spine.
Just a dot.
Just draw, yeah.
Just dot you mark. That's it.
Dot, not draw. What are you drawing?
Just put dots. That's enough.
Dots.
Yeah, so that
Total,
is one
huh, that's enough,
dot.
yes.
Now any other dot you want, keep drawing the dots. Little bit, probably a little bit more lower down. You want
Yeah.
how much skin you have, right? Now next one.
Then here there is a scar.
So do you want it on the scar?
Why are you going on this car?
Okay, so that means there is some confusion in your mind as to how to mark a true defect, right?
Apparent defect.
अरे apparently बोल दो.
This defect is it?
Here he is marked and then he will interpret other two.
You will get the true defect in the normal person, right? You have taken a normal person. Anybody else will be able to tell?
No, is that a scar or is it normal
Scar.
skin?
On the
Here it is
scar
normal
is
skin. That's skin, because on the computer it is looking normal. What you
Oh, on
looking
the
at scar?
computer it's looking normal, yeah?
Yeah,
This is scar. This is scar.
That is scar.
That is what-
This is scar.
Okay.
That is scar.
Come little bit lower down.
Mark it there.
Sir, this is
Yes.
scar.
Right, so.
Mark it there, yeah. Ah.
No,
No, it is junction of scar.
okay, but you want to finish with the alar one? No. In the middle of the scar, so there is confusion in your mind, that means how to mark, that it's clear, you have, is there anybody who would be able to give a clearer picture of how to mark a true defect, how to get your true defect from what is available? It is the same as one side ka agar you reflected on the other side. Similarly, you will do it for. Is there anybody who needs clarity on this? Nobody has clarity on You are afraid to come, says Rama madam.
Doesn't matter, if you make mistake, it is okay. Anybody
Come
can
over.
come.
Come
This
on.
is not a real
Somebody-
exam.
Yeah, you have to make a mistake.
Any
It's okay,
example,
don't worry.
any
It's not
example.
exam. Make mistakes here rather than making
Yeah.
exams.
So the point where the Ela
Show it. Just
No, no, show it on hand, yes.
for your music.
On your hand.
Shows the hand.
where it goes is very good.
Take do
Sorry.
pen and mark.
Okay, fine. Okay. And the Ela and the facial point where the Ela meets the facial.
Mark there. You see the laptop and mark. Okay. What else?
Then the glabella.
She's already got it marked.
Why are you marking in
Here,
the
here,
mark in the center?
and then,
What other point you will mark?
which is that? Because this is the point.
Where is the scar? Look at the scar. Where is the scar?
Ah. Very good.
Aja.
Very good.
Do you need anything with the columnar line?
Columnar base, the mid,
So what's that point called?
subbase is,
Subname.
And what happens to the flare of the columnar?
on either side of the columnar.
Okay, so these points are marked here. Same points you have to mark in the normal millimeter. Isn't it? And then you can measure. You have already
Then you
marked.
have to draw
Draw
dot
that
between
line.
that, वो जो
Distance measure करना है
top
ना
part
आपको.
of the scar, all that you join together, literally the whole of columnar you have to make. Then you will know at Ella के यहाँ से कितना है in the normal person. Then you will get a true difference. Okay. Since there's, I'm surprised there's such a so much of.
So if you look carefully at this, on the left side there is no ala at all. It is only that nostril sill which is there, and there's a very little attachment at this thing. So
The face.
that is why it's important to mark your points on the defect and transfer it, then you will get all your correct.
So since there is so much confusion, I just want to say there's a recent publication of mine which is on how to mark a true defect. Published I think in the Boston Burns, the journal Burns.
Another thing is that you mark.
Very simple actually.
Sorry. If you mark, better to mark on the normal tissue. What you are doing is always you are marking on the scar.
Just on the edge. Little bit, 1 millimeter below,
Nice drawing.
towards the normal tissue. Okay. Always mark like that.
Right side ala defect, you see that marking. It is way above the
Into this.
Normal.
way above the edge of the ala.
Can you tell me what are the tissues which are missing over here? What are the parts of the nose which are missing?
You can go.
Thank you.
Subunit wise columella is missing, sir. Tip is missing, sir.
That is the part is what he wants to know is what are the tissues, the lining, covers,
Yes.
skeleton.
Caudal septal cartilage is missing, sir. Some part of caudal septal
Okay.
cartilage is
Okay,
missing.
then
Then lining.
What about the septal angle? Since you're on the septum,
do you have
what is
lateral
the-
view?
what is the septal
Lateral
angle?
view?
Yes.
What is the septal
No.
angle?
The angle also missing because there is
What
no.
is the septal angle?
The angle between the quadrangular cartilage, septal cartilage to the columnar.
The dorsum with the
Dorsum.
caudal. Okay. So that's also missing.
So the tip is totally missing, so the obviously septal angle
Okay.
is lost.
Okay.
And then skin is lost, obviously visible. That is dorsum is
So skin of the of which
dorsum.
parts of the dorsum?
Dorsum, tip, right ala, left ala, and columnar.
Okay. Then
Then framework, that is cartilage support.
no.
Cart-
Once you talk about the skin, at the same point you talk about the next layer, either in between or on the depth.
cartilage.
You want to talk? Okay. You talk
Cartilage.
about cartilage.
Support.
Fine. What cartilages are missing?
So septal cartilage is missing. So caudal septal
Okay.
cartilage is missing.
Okay.
and then I'll go for the lines.
No.
Alright, cartilage.
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 So, okay, sir. The right ala and left ala cartilage is missing, sir.
No, so the inner cartilage has some parts to it. Inner cartilage has some parts. What are the parts of the inner cartilage which are missing?
Everything is.
What are the parts of the alar cartilage?
How many alar cartilages are there?
Two, sir.
Right and left.
Oh, super.
How many parts does that have?
And what are the parts?
Parts of ala is like ala base, ala.
No,
Parts of the cartilage.
You should read and you should know about the alar cartilage
Have you heard of
because
first?
they are great.
What are the parts of the alar cartilage? It has got what? It starts here.
Middle crest and lateral crest.
Okay.
Lower lateral
So these are
cartilage.
the parts of the alar cartilage. Okay.
And
So
then
what are missing?
above the lower lateral cartilage is
Upper lateral
So
cartilage.
is any upper lateral cartilage
Missing?
missing here?
It's missing, sir. It's going up to the rhinium, sir.
Oh,
Scar is
yes.
involved.
Very good.
What is the valve?
International
Internal,
nasal wall,
external.
external nasal wall, sir. Two
Yeah,
walls, sir.
yeah. Any of them missing?
Sir, upper lateral cartilage is missing, sir. So, international wall is all open, sir.
So where is the internal, where is the external?
So, internal nasal wall is bounded by the caudal septal cartilage inferiorly, by the superiorly the upper lateral cartilage, and then the lower lateral cartilage to the lateral.
So you have those, so you told us about the cover, you told us about the
Cartilage.
cartilage.
What about the
And
line?
something else
What is missing?
which is missing. You told us about the
Lining,
column.
sir.
Sorry?
Lining.
Line.
Lining.
So,
What part of the lining is missing?
vestibular lining is missing, sir.
Okay.
And then
And how
some
will
part
you,
of
how will you estimate that? Do you have an, so your diagram shows the outer cover, it doesn't show an estimate inner lining. So before you do the external, you have to do plan the internal lining,
this.
and you may or may not plan the cartilage. If we when you reconstruct the nose, you don't necessarily plan to
Plan for the-
replace.
replace the
So
lining.
principle that you follow is that you replace like with like.
Yes, sir.
But here you may or may not put the cartilage.
So let's see what.
Okay, what is
15
the
minutes
plan?
over. Let's see what you plan.
Routine workup.
Yeah.
Okay,
Just
okay.
plan.
Plan.
Surgical plan.
My plan is three-staged paramedian precise axial trilaminar full thickness folded flap, sir. First, I would like to reconstruct the skin, that is envelope, and also the lining, sir.
So lining with the same flap.
Same folded flap, sir.
How will you fold it?
And he has got some. You got some four diagrams for this?
You have got the link. You have
I got the link.
Ah, link. Show us on the. Take it there and show us.
So if I plan the flap like this, sir, these are the right ala and left ala, and when I flap this, so I will fold it like this, sir. So the columella will be the support, and then this flap
Where is the
will
columella in your diagram? It is quadrangular, no? Is your design quadrangular?
So just
When you are
put
reconstructing the
your,
column.
No, sir.
put your pattern, just bring your pattern there on the light. Just put the pattern on the light. Then you
Like,
like.
yeah.
3 into 2 centimeters.
No, so
But this is not your pattern drawn?
Not in this patient, I have drawn on the photo, sir.
Photo
The
here.
design.
Don't you think this flap lining and cover will be too bulky?
Sir,
And your flap is going to collapse without a skeletal support?
first stage I am going to do a flap, sir. And second stage I am going to do a flap thing, sir.
Okay.
So it's a child.
So all things will collapse.
No, sir, he can do it in second stage. That is permitted.
Let us see what.
Before you divide the flap, you must reconstruct the cartilage.
Cartilage.
Otherwise, it is going to sink.
Yes.
So either in your first stage or in your second stage, you must do framework reconstruction. So when you are doing your framework reconstruction, when you are thinning the flap, that is acceptable. But you must do it before you divide the pedicure.
Yes, sir. I am going to do the flap division in third stage, sir, after 4
Third
hours
stage.
of
So you are reconstructing the cartilage in your second
second stage.
So what all will you reconstruct in your second stage?
Sir,
And in the first stage, how are you going to give the lining?
first stage I am going to give lining along with the skin, sir, envelope which is folded for it flap.
And the same folded thing is going to reconstruct the columella. If you fold it, how will you reconstruct the columella? This design, if you fold,
Yes, sir.
how will you reconstruct the columella?
Require extension no, for the column.
We can do a modified seagull shape wing, sir.
Show us, no?
Yes.
Modify that drawing. No, you can go there and show us with finger. Finger से दिखाओ कैसे change करो.
Don't mark it.
Yeah, don't mark. Just show. Yeah.
So, like this we can make a seagull.
Yes. It
Modified.
doesn't like a seagull.
Yes, sir. But
But you have to the extra. He has taken extra, doesn't it?
because folded then see and
You will sacrifice whatever you take.
Are you in a position to provide the lining by using a local tissue?
Yes.
this is a child, sir, 6 years old child.
So much scar which
So
is
much,
there,
yeah, so
you
much
can
scar.
just turn it down and you can use it for the
Yes.
lining.
What is that called when you use?
I didn't understand.
So much surrounding skin it is available for your nasal lining next to your defect. Why you want to insist on our lining by using that thick
Yeah.
forehead flap? Nasal lining is thin.
Yes, sir.
You want to have a thin nasal lining.
Can you use the scar?
Yes, sir. There is car-based hinge over flaps. We call them.
Hinge over.
International flaps.
Can you use the right alar to give the lining? Right alar, the normal skin. Can you turn it towards the tip? Right alar, left alar, whatever is available, can you turn it? Normal skin. I am talking about normal skin of the right alar and whatever is left on the left side.
For lining, sir.
For lining.
Yeah, we can use it. The scar-based or
That is not scar, that is normal skin.
normal skin.
Right alar, normal skin.
Hinge over flaps.
Can you do it?
Yes, sir.
Will you sacrifice that normal skin for hinge over flaps?
We can do, sir.
No, will you? Will you? Or will you not? And if will, what is the basis? What is your logic for that?
If I use the normal skin for the lining, sir, I understood. And then
You don't think there is a normal skin here, correct? This skin.
yes, sir.
That is normal, that is not scarred. So will you hinge it, will you turn it over to give lining?
Yes, sir.
Yes.
I can use.
Yes. What is the logic behind it? Why are you sacrificing the
What is the principle?
What is the principle?
Subunit principle, sir. So in this, if we did the defect is less than 50%, we have to dissect the complete subunit and then you have to reconstruct the whole subunit.
Okay.
So, in
So
this-
when you are giving the cover, you will cover both the AV,
both
the columella and the dorsum.
And the dorsum.
Correct? So whole thing you have to reconstruct as one unit.
one unit.
So your lining problem is solved.
Yes, sir.
What about membranous septum?
For the columella and tip, I am going to the Elstrad flap, sir.
No, membranous septum is lining.
Lining. The folded forehead flap.
Folded forehead flap can be used for membranous septum, but not for the tip and alar lining. Okay, so that there you can use the local skin. But you may still have to fold the forehead flap for the membranous septum because columella is not only columella, it has some depth.
Yes, sir.
Correct? It has to reach the cartilage septum. So you require these two panels plus the visible columella. Correct? So there you may have to fold it. So again that design would change, the distal design.
And then white so that the columella can be used.
Why not primarily reconstructing the cartilage and on the top you can put a flap?
We can do, sir, but I would prefer to go for first to raise the flap. Do legs.
Preference should be primary reconstruction.
Have you seen the procedure of forehead flap reconstruction 3-stage?
I have seen 3 stages, sir, but I have seen the cartilage grafting in second stage.
No, second stage is allowed. It is a done thing. But preferably it should be done in the first stage.
First stage.
If you are not sure about your lining, if you are not sure about your cover, you may do it second. In second sitting. But preferably it should be, otherwise your flap is going to contract.
But it is very difficult to raise the flap to create a plane which is necessary for reconstructing your columella strut, reconstructing your dorsal strut, reconstructing your both the alar cartilages. You have to reconstruct entire thing. Better is to reconstruct the lining, lacing your cartilage framework under vision. Good strut, good dorsal strut, good alar cartilage. On the top you put a, it's like a hanger, putting a coat on the hanger. Your hanger should be there first, and then put a top on the top a coat of you can do an expanded forehead flap in order to get it is wide, but even you get a better closure aesthetically, but you get a good large expanded flap, reconstruct your entire aesthetic unit. So best option is to put in an expander. You expand the forehead flap and you get adequate amount of skin. You can get additional skin for your nasal lining at the margins of your alar cartilage.
What else is there? You have got something more?
Second plan, sir, light board plan.
Nobody does wash your flap. It is only in books.
But
Nobody
even if
does
you're
it.
doing it, the designer is not
And this is
correct.
also not correct what you have.
You know, there are measurements and there's a particular design. The basis of it is that it is a triangle, the shape of the triangle is in the washer flap.
Washer flap, AC
construct
triangle, sir.
your
Yes,
the size of the triangles are. You get isosceles
isosceles
triangles or you
triangle
get
and then it is
or equilateral triangles.
isosceles triangles. Two
Read
sides.
read about the washer.
You have to switch over so that it has to be, both the lengths have to be equal, then only it will
Yes,
switch
sir.
over.
Yes, sir. I have
And then your hairless area is also bearing the hair. The part which you want to reconstruct the tip of the nose is also bearing the hair. So that is in washer flap, the tape.
Mastoid skin and post-auricular
Yes.
skin should be hairless regions. That's the picture.
That has to be used. Anyway.
And what's the vascular basis?
Cartilage.
It's the anastomosis between the superficial temporal artery and the post-auricular arteries.
So the marking,
The base of the flap should be AB and then
so A cannot be on the helical margin, it has to
C
preserve.
also can't
preserve
be
the
so high.
superficial temporal artery axis.
Yeah, that's fine, correct.
A has to be lower down, C also needs to be lower down. Then only it will. What else?
For cartilage framework, maybe you have.
Osteochondral cartilage. Rib cartilage. It's the best, better for the L strut, for the tip and columella. And then fongal cartilage that can be for the alar. Non-anatomical.
Same costal cartilage.
Same, why not use fongal when
You
you are
can use the principle of perichondrium which is closed. You can pick a sliver. The perichondrium will bend like this, like your cartilage. Both sides you can put.
You are harvesting this,
outside.
you are harvesting this anyway, no, the causal cartilage. Then why want to harvest fongal cartilage? You have adequate cartilage there and you make it very, very thin so that it will mimic your fongal cartilage, mimic for the alar. Make it very, very thin slice. It becomes pliable.
What else you have, what slides on?
So these are done in my hospital in which same tip columella. We did after debridement the parameter 2 stages.
This will stage.
Yeah, we didn't reconstruct cartilage, sir, framework. The patient is satisfied.
The only question of patient is
He
satisfied.
didn't turn up, sir. We asked for
See,
the.
this is the lesson to learn. When you use forehead flap, you always do not require a framework. If your septal cartilage is intact, you can manage the alar defect, especially if it is 50% or less than 50% without any skeletal support. Because the galea, that takes care of the support. You don't require framework for this. The tip is intact.
Yes.
Next.
And the other difference in this from the patient that you had is that he's got a very small lining defect, which you can do with a folded forehead. You cannot get more than the vestibule with your folded forehead flap. You won't get the columella plus that.
Skin.
So you have to have a separate inner lining from the same. This whole thing will pull up and the whole thing will collapse. So here it's much smaller.
And this is 2 stage.
This is 2 stages.
And the pedicle which you have made is almost like a island. The one diagram you have made, and you see the pedicle made here. You can make it what you are saying, but in practice, most of the time we do this, and usually we tend to put that back with a small triangle.
Small triangle, inverted V triangle.
Inverted V. You don't want to put parallel to incision because you will see more scars.
Scar patients.
Next case you have.
No, sir.
Your life
Enough for the
board,
day.
your life board should have,
Enough for the day.
it should have been a free flap and not a vasio flap. A life board should have been basically if you are using forehead flap and if you are giving a life board here, something is wrong with your skills. When you are using a forehead flap, you don't need a life board. Yes or no? If you are getting a life board for your forehead flap, then something is missing. But if at all you want to have a life board, it should have been a free flap. Which free flap would you have used?
Radial forearm. Radial.
If you use radial force, then definitely you require the skeletal support at the first stage itself. But forehead when you use, it is not essential for him.